So I joined the lab and I said, Dave, I want to put drugs in the mouse and I want to try and cure them, and then we'll put them into people. And he said, great, that's wonderful. Tell me which mice have cancer. Because just like in patients, these mice don't present with symptoms until they're just a few days away from death. And so, I was immediately dumped into the deep end of learning how to image mice. And so that's how I got into this. And I begged, borrowed, and scraped time from a variety of different instruments around the campus of the University of Pennsylvania, and had the opportunity to try out a Vivo 770 at that time, the earlier generation of the current machine. And the very first time I picked up the transducer and put it onto a mouse, I did see the tumor. And so that's actually why I ended up using this instrument, was because I didn't have to get a second PhD to learn how to use the instrument. And I was able to, we were able to acquire a machine and put it in the room with our mice, and then the mice didn't have to worry about, we didn't have to worry about going to other facilities. And so it worked out pretty well, and we were able to look at a fair number of mice pretty quickly. And so I was able to set up intervention trials where we would treat. And so I decided, well, let's take gemcitabine and put this into our mice. Because, could be that our mice actually responded really well to gemcitabine. That would be a problem for the model because it would mean it wasn't very predictive of the clinical experience. So we had to do that experiment. And so this is just a short-term intervention trial, but it gives you an idea of the type of drug study that one can do with a good imaging modality, where we're just looking where this line is at the 12 days following the onset of treatment. And what you can see is that the majority of the mice, whether they're treated with saline as the vehicle, or 50 or 100 milligrams per kilogram of gemcitabine, which is a chemotherapeutic agent, the majority of them don't respond. I've actually put in the 2 mice that did respond. These were the only 2 mice that showed a change in growth kinetics in the entire study. So it was 2 out of 17 response rate. And you can pick them out. You can say, look, these are growing, and this one, a couple days after you start treating, changes. So it's a rare response rate, and it's roughly the same response rate as we see with human pancreatic cancer patients that are treated with this disease. But to my knowledge, this was actually the first mouse model of innate chemoresistance, primary chemoresistance. So I began to become really interested in this. And there are many examples of genes in the literature that have been described as being involved in resistance to gemcitabine. And I looked at them, but we didn't really see too much. I had this feeling that it wasn't a cell autonomous effect, because we had done this experiment where we took these tumors that were predominantly resistant to gemcitabine, stuck them into tissue culture for a couple passages, and then put them under the skin of a littermate mouse with an immune system. Made allograft tumors. And these tumors were all sensitive to treatment. So I began to think that this was a non-cell autonomous effect, and it had something to do with the in situ natural microenvironment of the tumors. And so I began to ask the question, is the drug even getting into the tumor in the first place? And so this is where, this was my first experience with functional imaging. We got some microbubbles. So we ordered them and injected them, figured out how to do IV injections. And the very first mouse that I looked at had this kind of interesting pattern. So this is an abdominal tumor. It's going to be a little bit hard to pick out on the screen here. The tumor is outlined right here. This is where it is. And what you're going to see is the contrast agent flowing into the picture, but it's going to flow in around the tumor. And it doesn't flow into the tumor at all. It flows into the surrounding tissues. There's really very little perfusion in these tumors by contrast ultrasound. And it turns out this experiment was actually done in humans. No one knew it because it wasn't prominent literature. But it turns out that there was at least there were actually 2 papers that showed that pancreatic ductal adenocarcinomas are hypoperfused by contrast ultrasound in the clinic. And so what you can see is this is a contrast ultrasound on a patient with ductal adenocarcinoma of the pancreas. This next patient here had endocrine carcinoma of the pancreas, which is a very well-perfused type of cancer. And so you can see that already there's this kind of co-registry between the human and the mouse models, and that gave us a little bit of confidence to go forward with this.